So I'm going to speak about the intraoperative MRI and brain tumor surgery. There's no conflict of interest to disclose. The learning objectives for CME purposes are hopefully the audience will have a better understanding of the technologies available for identifying tumors intraoperatively. And I'll speak about the current technology and then the future technology, the differences between the various intraoperative MRI systems. There are 3 or 4 options out there now, and then the tumor types that benefit from resection in an intraoperative MRI suite. And I'll just go briefly through some studies that have been published to date. So just as background, brain tumors, it's not a huge public health hazard, but it seems that everybody knows somebody who's had one or has one. There are 21 per 100,000 in the 100,000 in the United States, and that's according to the Central Brain Tumor Registry of the US, and that translates to about 65,000 per year, which leads to about 13,000 deaths per year, according to the latest statistics. This is a breakdown of the type of common brain tumors. On the left side, going down the row or going down the column, are various types of tumors. If there's a colored bar on the left, it's more common in females. If there's a bar on the right, it's more common in males, and that satisfies the gender portion of my talk. Brain tumors, in general, there's a growing consensus, and there's actually still some debate that the more of a tumor you take out, the better the patient does. And so intuitively, you would think that that would be true. But at every annual meeting, there's still a symposium where people get up there and debate this. But I think that in general, people would tend to believe that. The current state of technology that's widely used is something called stereotactic navigation. And so when a tumor is removed, and this is particularly true for tumors that are deep in the brain or have irregular margins or have large cystic components to them, if the tumor, and often this does occur, the tumor looks just like brain tissue or feels like brain tissue, it's sometimes hard to figure out how much to take out, where to stop taking things out. And so it becomes a little bit of a challenge. And so we often use something called stereotactic navigation. And it's a technology where a patient's MRI or CAT scan, in this situation it was a CAT scan, is done. And then the computer turns it into a 3D image, and then you can see the planes there, and this is an example of a pituitary tumor that was being taken out. This is a patient who actually just had surgery this week. This is a gentleman in his 60s who had this mass on his brain MRI, and this is an axial T1 weighted image, and the white stuff kind of in the middle of the brain in the pons is the tumor, and he had multiple other lesions through his body, and so the thought was that this was perhaps a metastatic lesion. And because of the other lesions in his body, we recommended that he have one of those other things biopsied rather than his pons, for good reason. So he had a biopsy, and the biopsy came back lymphoma of indeterminate type. And nowadays, it actually matters what type of lymphoma you have because it tailors treatment. And so 3 or 4 weeks after this scan, he came back, or he was sent back to see me, and the oncologist said, please do a biopsy. We really need to know what type of lymphoma this is. And I said, okay, we'll give it a try. And he'd been put on steroids at the time of this initial scan, and if anybody's familiar with steroids and lymphoma, the tumors magically disappear. And so this is the scan that he showed up in my office with 3 weeks after I initially saw him. And so the goal was to biopsy this thing. Now, this is probably dural based. That dark, obviously the tumor is where the arrow is, and that dark area next to the tumor is bone, and bone doesn't show up on MRI, and that's why it's so dark. And so to get at this tumor would be a standard acoustic neuroma approach. There's some landmarks. The 7th cranial nerve is there. The 5th cranial nerve is nearby. And so I should be able to find this pretty easily, but I chose to use stereotactic navigation in case this tumor got even smaller in between the time that this scan was done and the time of surgery. And so I'll show you an example of how stereotactic navigation works. So what we do is we do the MRI, we do the 3D reconstruction on the computer, and then in real time, we take this probe, which is shown on the left, and when we point to an area on the patient's skin, you see a virtual reality image of the probe on the patient's MRI. And so using this technology, one can find where a tumor is and delineate its margins, at least based on the preoperative MRI, and then try to take this tumor out. So this was the exposure. This is the tumor. On the right side is the 7th cranial nerve, and just to the left of that is the tumor, and so it hadn't disappeared completely. And so this was biopsied. This is the intra-op, and you can see that on the upper right-hand corner, there's a little metal probe sticking into the tumor, and then you can see on the MRIs during surgery where the probe is relative to the preoperative MRI. And this is a case where this technology works perfectly because the tumor is up against the bone and the bone's not going to shift. The brain has shifted, and in the upper right, along the bottom, that's a retractor, and the retractor has pulled the cerebellum down, which allows access to that tumor, but the movement of the cerebellum is not reflected in the preoperative MRI, and so that becomes a problem with certain tumor types and a lot of tumor types. And that phenomenon is called brain shift, and this is an example of brain shift. So the image on the left is a preoperative image of a patient's tumor, and then immediately to the right is a postoperative image, and then again on the right-sided pair, it's a pre-op and post-op image. And you can see that if I took out everything based on the pre-op image, which would be the left, I would have resected this patient's motor cortex. Because the brain shifts, it shifts, it fills in, it moves. And so all of the tumor was taken out, as can be seen on the right, but had I used the preoperative MRI guidance system throughout the case rather than just initially, I in fact would have taken out the patient's motor strip. So one of really the pioneering solution to brain shift is the intraoperative MRI, and this is a photo of the world's first intraoperative MRI. It was installed in 1994 at Brigham and Women's Hospital while I was a resident there. And in the upper image, you can see that you're looking straight on at two rings, and the patient gets slid in through the rings, and so it was referred to as the double donut. The patient went in through both donuts or settled in the middle, and then the surgeon stood in between the two. And you can see on the lower panels, the surgeon's back is to you and the scrub nurse is there. And as the surgeon steps away in the lower right-hand image, you can see the patient's head, which is where the surgery was done, obviously. And the surgeon is draped in the front and the back because both walls of that magnet are technically sterile. So this was really a pioneering advance in surgery. And so what this allowed the surgeon to do was to take out some of the tumor, the brain shifted, you can get another image right there and then see where you were and take out more tumor as you needed. There were a number of shortcomings to this system. One was the strength of the magnet. So this was a 0.5 Tesla magnet, and Tesla is a unit of measurement for magnetic field, not a car. But nevertheless, half a Tesla is a standard diagnostic MRI machine nowadays is either 1.5 or 3 Tesla. And so the quality of the images is much less or not quite as good with a half Tesla magnet. And because the because the surgery was done within the magnetic field, we could only use non-ferromagnetic instruments, meaning that it was mostly titanium. And there are a number of instruments such as the Bovie electrocautery, which is one of the mainstays of surgical equipment, couldn't be used in that environment. And so to overcome some of these limitations, various different systems were devised. This is from Medtronic. And in this one, the patient is placed on that operating table shown, and the magnet apparently goes up and goes down, and so that it's a little bit out of the field, so you don't have the cramped environment that the Brigham machine had. This is the iMRI system, which is in use at the MGH, and in this situation, the patient's surgery is done here. This is the operating table here, and then this magnet is installed on a track here, and the track brings the magnet into the field, and the patient is scanned. And so again, I presume that you can use instruments that are magnetic. You just remove them when you scan the patient, and this allowed for the use of a much higher Tesla magnet. This is a third option, and this is a mock-up of what's being installed at Cottage Hospital. And in this situation, this is an operating room, and the patient's surgery is done here. And then in the middle of surgery, if a surgeon feels that a scan needs to be done, the patient is transferred to this trolley, which is then wheeled into this next room here. And then the patient comes from this room in here and then is wheeled into this room and is placed in the magnet. And so this allows for the use of a higher strength magnet as well. And it also allows for the use of magnetic instruments in this room here, and the instruments are left behind, and so it's safe to bring the patient into this area. And so with the use of this technology, and there are a number of places around the world that are starting to use this, people have wondered, well, does it really help patient safety? Does it increase patient care and efficacy of these procedures? And so there have been a number of studies, and this is from the Brigham group. This was for low-grade gliomas. It's one of the more common indications for the intraoperative MRI, and this was a retrospective study of 156 patients who underwent surgical resection of a unifocal supratentorial low-grade glioma that was thought to be resectable. With the use of the intraoperative MRI, the percentage of patients who had died at 1 year after surgery was only 1.9%, and after 2 and 5 years it was 3.6 and 17.6. And remember, I mentioned the Central Brain Tumor Registry of the US. These are historical, what we refer to as historical controls. So the typical patient, or if you take all comers within the US, a similar patient population after 1 year, 12 to 26% of patients have passed away, 18 to 38 and 31 to 53 patients, depending on the exact histology, have died after 1, 2, and 5 years. And so the authors postulated that the much better survival may have been due to a more complete tumor resection, but the study was a retrospective study and it wasn't powered to show this difference. So they couldn't really make that statement, but they speculated or conjectured that that was the case. This is a German study on malignant gliomas, and this was a prospective randomized trial of 58 patients. So they had 58 patients who showed up who had tumors that were amenable to resection, or what was considered amenable to resection. The patients were randomized into either the standard MRI group or the standard neuronavigation group. And then 4 of the patients in each group turned out to have metastatic tumors, so they were not included in the analysis. And then one of the patients in the MRI group decided to leave the study, so they were not available for analysis. But out of the patients who were available for analysis, complete tumor resection was achieved in 96% of the patients in the iMRI group, while only 68% of the patients in the standard neuronavigation group received the complete resection. And so this was evidence that a more complete resection could be carried out, and whether this translates into higher survival is still up for debate. But as I said, the general consensus is that that would be the case. This is pediatric tumors. One thing about pediatric tumors is for many of the different types that can occur, a complete surgical resection or getting all of it out really can make a significant difference in how long patients live, and that has been shown in multiple studies. And so what typically happens is a pediatric patient will have one of these tumors taken out, and either the day after surgery or even that afternoon or evening, they'll have an MRI, and if the MRI shows any residual tumor, they actually will be taken back to surgery the next day to get the rest of it out. That's how critical it is to have all of the tumor taken out. And in this single institution study, I think this was St. Jude's in Tennessee or Memphis, they looked at 191 patients who underwent intraoperative MRI guided surgery over a 2-year period. When the surgeon thought that they had taken out all of the tumor, they got an MRI, and they found that actually 21% of the patients still had tumor. And so because it was in the middle of surgery that they had this MRI, they could just continue the surgery, take the rest of the tumor out. They found that the early reoperation rate for these patients was less than 1%. So they had 1 patient out of 191 who had to go back for early reoperation. And the reason that patient even went back was because the diagnosis on the frozen section had been misleading. And so they decided that they should go back and take more tissue out when they initially thought that they didn't need to do that. And then they looked at the year prior to the installation of the intraoperative MRI, and they found that their historical rate of reoperation was 8%, and this was statistically significant. So in this patient population, this was really a very important advance. This is a review article on the use of intraoperative MRI in pituitary tumors, and I saw that at MGH they're using this, they're doing transphenoidal pituitary surgeries. And this is a review article, and they found 9 out of 9 studies which correlated or which found good correlation between the intraoperative MRI findings and the postoperative MRI findings. So this is with pituitary tumors. They found that 24 out of 24 studies examining the use of intraoperative MRI to achieve a more complete resection, or 24 out of 24 studies showed that the surgeons felt like they had a better resection with the use of the intraoperative MRI. And 2 out of 2 studies compared the ability of the intraoperative MRI to find residual tumor tissue that the surgeon didn't know was there versus using intraoperative endoscopy to look for tumor. And they found that the intraoperative MRI was more effective than using intraoperative endoscopy, which is the current standard of care. And this was particularly true for tumors located lateral to the sella, within the cavernous sinus itself, or in the suprasellar space, which are areas which are a little bit harder to observe directly with the endoscope. So this is an example of the use of the intraoperative MRI at NIH when I was there. So this, on the far left, is the postoperative, preoperative scan, I'm sorry. And this is the tumor here. So this patient had surgery, and I took out what I thought was most or all of the tumor tissue based on its visual appearance and its texture. We got our first intraoperative MRI scan, and you can see that I actually left a little bit of a corner there. And the reason is that I used neuronavigation to define the margins of the tumor, but once I started to take out this half of the tumor started to collapse. And so I ended up going underneath this part of the tumor. The surgical approach was through here. And so this piece of tumor would have been up and underneath our surgical trajectory, and that's why it was left behind. But it was noticed during the scan. So we went back and took out what I thought was all of this tumor. We got a second scan, and this is probably not tumor because it doesn't correlate to the shape of this. And so this is probably some bleed-through enhancement just from some trauma or injury to the brain. And this is a critical distinction to make during these surgeries, that the radiologist and the surgeon appreciate what's tumor and what's enhancement from the intraoperative trauma. This is also a pretty dramatic example of brain shift. So you can see here, this dark area, this brain used to be up against the skull here, and over time during surgery, this whole brain has sagged. So the preoperative neuronavigation system is completely off. So this area was left alone because we recognized that it was probably some trauma to the brain. And this is the postoperative scan a few months later, where there's been some retraction of the cavity, but you can see that this enhancing area here is no longer apparent even though we left it alone. So this is a typical example of how the intraoperative MRI can help achieve a more thorough resection of these tumors. So in conclusion, the intraoperative MRI can increase the extent of resection of tumors because tumors can grossly resemble normal brain. Tumors that are located deep within the brain are sometimes difficult to identify the margins of, and tumors that have irregular shapes also are difficult to exactly identify, particularly when the brain has shifted. The intraoperative MRI can improve patient survival and quality of life secondary to increased extent of tumor resection, and this is particularly true in the pediatric tumors. It can prevent the need for early reoperation of tumors, and the Santa Barbara Cottage Hospital intraoperative MRI is opening in late 2015, and we hope to do our first case in the beginning of the year. This is the intraoperative MRI being installed. It's kind of a tight fit there coming down the hallway. They had to take it, I guess they had to take it apart, or they had to take part of it apart to get it around the corner. This is them putting it into the room where it's going to live. This is the actual MRI in the actual room that it's going to be in, and this is a 3 Tesla machine, so we'll get much better images. And so I think this represents the state of the art in intraoperative tumor removal, I would say, and I think this technology will spread to other areas as Dr. Zahner will also use this machine quite heavily. And I'd like to acknowledge Dr. Jones and Dr. Zahner for their vision in having this planned and built. Lisa Moore and Gary Milgram for really executing the purchase, the construction, and the approval of this machine, and the Cottage Hospital Medical Advisory Committee also for their vision in having something like this installed in a hospital of this size. I'm just a Johnny-come-lately to this project, and I think these people really deserve congratulations for having this come to fruition.